Hi, I'm Dr. Shirjeel, and today I would like to present the second phacoemulsification case. In a floppy iris, the pupil is not dilating, so it's a mid-dilated pupil, grade 4 nuclear cataract. We have made the cystotome as you have seen, and now we will proceed towards the construction of the main port at 12 o'clock. We have stabilized the globe at 6 o'clock, and now very slowly into the anterior stroma and then into the anterior chamber with 2.75 phaco knife. Very gently make sure that you don't peel the decimates and you don't rupture the anterior capsule. Now, as it's a mature cataract, we will stain the anterior capsule with trypan blue dye, and after staining, now we will put the viscoelastic to maintain the anterior chamber depth. Now we will make the two ports. As you know, I make the smaller port at 10 o'clock, whereas the larger port between 2 and 3, with which I also do fine irrigation aspiration. Now, another most important rate limiting step, with the help of cystotome we will do Capsulorhexis. In hard cases, try to make a smaller Capsulorhexis. Capsulorhexis should not be very large, and there is a positive pressure in the capsule. So if you feel positive pressure, sometimes you don't feel, like in this case we don't felt any positive pressure, so we continued our Capsulorhexis slowly, gently, and we succeeded to do the Capsulorhexis in one go. So that's a very important. If you do a round Capsulorhexis, then the rest of the phaco becomes very easy. Now another very important step, hydrodissection. Make sure that you are under the capsule, because if you are above the capsule, then you can damage the annules, you can dislocate the bag. So make sure you are under the capsule, then sweep and try to do as much hydrodissection as possible. Try to rotate the nucleus because it will make your next step extremely easy. Now here the machine, Otley machine with which we will do this case, the settings are 70 phaco power, 350 vacuum. I do all the case with one setting. Now we have inserted the phaco probe, and with the second instrument I use dialer. We will make a groove, little bit trench as well in this case because of its hardness, and then we will try to divide it. When we divide the nucleus into two, the pupil starts to constrict. As I told you, it was a floppy iris, so then it will become very difficult. The phaco becomes very difficult when you do in a constricted pupil. So now here we are emulsifying the last nucleus piece in the anterior chamber, because the pupil is pinpoint. When you are forced to do the phaco in the anterior chamber, then try to put as much viscoelastic as possible, and also make the direction of the phaco downwards, so that you should not damage the corneal endothelium or cornea. Here you can see the yellow brown nuclear pieces, the last pieces which we are emulsifying with the phaco. and you can also see how much constricted the pupil is. But thanks God, without any complication, we have completed the emulsification of the hard nucleus, and that was possible because of a good constructed wound and a good capsulorhexis. Now fine irrigation aspiration through main port. But that this step also becomes difficult due to constriction myosed pupil, but still you can sweep the cannula under the iris and you will get the cortical matter. Now with the side port, I do fine irrigation aspiration more comfortably with my left hand, and I also use the foot pedal of the Phaco plate under my left foot. So these are the remaining cortical pieces that I would like to remove. So what are the intraoperative complications of the phacoemulsification? You can damage the iris, you can do PCR, you can damage the cornea, you can do the decimate detachment, you can damage the you can break the granules, you can cause hyphema, hemorrhage of the iris vessels, you can remove all the capsular bag and make the patient aphakic, you can drop the nucleus. These are the intraoperative complications of the phacoemulsification. Now we are inserting the foldable intraocular lens, and you have seen how we fold the lens into the injector. Now slowly and gradually we are putting the foldable lens into the eye. Due to constriction of the pupil, the lens was in the anterior chamber, so with the help of the dialer we are putting the intraocular lens into the bag. And the post-op, the most common complication is corneal edema, posterior capsular opacification.